Hello, welcome ladies and gentlemen to today's tutorial. Today we are going to look at bone tissue. That's histology of bones. I'm actually going to start with some key concepts as lay the foundation. We look at the various kinds of bones based on shape. Yes, we also look at compact, and spongy bones. We actually look at the components of the bone tissue. Yes, we look at the cells. We actually will also be interested in looking at the organic matrix. Yes, the inorganic component, as well as water components that form the bone tissue, and then link it to some pathology that relates to the bone. We actually also be interested in knowing the various kinds of bone formation. Yes, talking about intramembranous and of course endochondral. Yes, ossification. We'll also be looking at them. And intermittently we'll be looking at some bit of short questions to try and then keep attention, try and then assess our understanding regarding the subject matter. So without much ado, yes, let's go through this bone histology. There are some key concepts that we have to understand. Yes, importantly is for us to understand the importance of the skeletal system. Now, actually, when we talk about the skeletal tissue, it consists of two things. We're talking about bone as well as cartilage. Yes, by way of the skeletal system, it's very important to know that the skeletal system is going to protect. Yes, going to form the framework of the body. Yes, protect it. It's also going to be important in giving a support. Apart from that, it's going to, provide surfaces for attachment of muscles. Yes, one thing that you have to know is that muscles who are attached to bones via what we connective tissue we call tendons. Then of course bone to bone will be by way of ligament, but muscle to muscle will be by way of aponeurosis. Now, one thing that is also very important is that yes, apart from what the bone is going to do these ones, it's also going to have what we call red bone marrow, which will be important in hematopoiesis, that's production of blood cells by way of blood cells which come from the myeloid lineage, being the red blood cells, being the white blood cells, of course platelets. Yes, apart from these ones, we also have what we call yellow bone marrow. Yellow bone marrow will be relevant in what we call fat storage. Now remember that in the fetal life as well as in early childhood, what happens is that we have more of what we call red bone marrow than yellow bone marrow in these long bones actually. And what will happen is that as you grow, most of these red bone marrow will be replaced by what we call yellow bone marrow. Now remember that it is an irreversible phenomenon which take place, so that under no means will the yellow bone marrow will be converted to what we call red bone marrow, even in disease state where the need for increased erythropoiesis or hematopoiesis is needed. Yes, apart from that, they will also be relevant in what we call storage of minerals, mainly calcium and of course phosphorus will be stored by the bone. Therefore, their metabolism, yes, will be dependent on the bone as well. So when we look at in the later section, we look at how the parathyroid hormones, the calcitonin and the calcitriol will be relevant in actually regulating blood calcium, levels as well as bone calcium, levels. Now, importantly, when we talk about what we call osteology, yes, one other thing that the skeletal system will be very important in will be actually to help in movement. So they serve as leverage for muscles to actually, as well as ligament, to enhance what we call movement. So that yes, together with that, muscles and associated ligament, they are going to help in movement. They will also be important in giving shape to the body. Now, anytime we talk about osteology, then we are talking about the study of bone. The word because osseous has to do with bone. So when we talk about osseous tissue, which will be relevant, which is the main thing that we are going to learn today, is actually the tissue being the bone, osseous tissue. Now remember that this osseous tissue, yes, the newly formed osseous, yes, structure that will form will be called osteoid. That's the newly formed organic matrix of the bone tissue is called osteoid, which should not be confused with what we call osteon, and osteon is seen in compact bone forming what we call the Herbacean system. And then of course we also be looking at what we call osteogenic series of cells. Yes, talking about osteoprogenitor cells or osteogenic cells. Yes, osteoblasts, yes, osteocytes, and of course osteoclast, which we are going to see all these ones. Now we'll also be thinking of some disorders by way of osteoporosis, especially in situations where osteoclast activity, which I will explain, bone resorption outweighs what we call bone formation or osteoblast activity. So we actually be interested in actually explaining these ones when we get there. Yes, again we have what we call osteomalacia. So osteomalacia has to do with the mineral component, which we actually be explaining it. That's in adults, where the mineral component is low, leading to actually brittle bones or weak bones, actually bone curving, and that's what we call osteomalacia. But in children we will call it rickets. Now, of course, ostalgia has to do with bone pain. Algia has to do with pain. So anything that has to do with osseous, has to do with the bone. And of course, osteomyelitis, that is inflammation of the bone. Yes, mainly going to be caused by bacterium. Yes, mainly staphylococcus aureus will be implicated. Yes, either coming from a bloodstream, hematogenous means to cause this, or it could be by way of some surrounding tissues being affecting the bone with that kind of pathology. Osteomyelitis, inflammation of the bone, bacterial, being caused by bacteria. Now, bone could be a tissue or it could be an organ. Yes, regarding what we are going to talk about today, we know bone is a tissue. Yes, going to have these cells forming cells of the osteogenic series, but it could also be an organ. Yes, because the bone tissue, you find that it will be related to what we call periosteum and osteum, which are connective tissue. There will also be blood vessels, there will be nerves in there, they will be associated with muscles. So actually, yes, once we know that a tissue, an organ, is actually formed from two or more different tissues, then of course the bone can be classified as an organ, because of course the bone is vascularized. Yes, there are blood vessels, there are nerves. Yes, even associated with some kind of muscles as well. So that is one thing that we have to actually understand. Now, by way of classification, generally, yes, based on shape, we can have 5 kinds of bones. So as you can see, the first one, we have long bones. Now, long bones are longer than wide, as we can see in the case of humerus, in the case of radius ulna, yes, tibia, fibula, femur, metacarpals, phalanges, metatarsals. Of course, these are actually miniature long bones. So these ones, yes, will have what we call 2 ends. As you can see, there will be 2 ends, bulging portions, in the case of the humerus that you find over there, and there will be an intermediate long portion known as the shaft. So there will be 2 ends known as epiphysis. Epi means above, so there will be proximal epiphysis, there will be distal epiphysis, and then connecting them will be a diaphysis. But there is transiting from the epiphysis to the diaphysis, there will be what we call metaphysis. So that is one thing that we are going to find regarding these kinds of bones mainly. So that is one thing. Now again, the next one will be short bones. Now for short bones, they are short, as the name suggests. They tend to be roughly cuboidal, so that they are as long as wide. But yes, sometimes they will be wider than long. Yes, but mainly they will be short generally. Now examples mainly will include bones of the carpals, carpal bones, or the bones of the carpus, yes, bones of the ribs. Talking about scaphoid, yes, lunate, trapezium, trapezoid, capitate, hamate. Yes, these ones are actually going to be what we call short bones. But remember that there's one bone over there in the wrist known as pisiform. Pisiform is not a short bone, it's actually a sesamoid bone, because it's found in a tendon, which we call it tendon of flexor carpi ulnaris. So that's one thing that you have to know, that pisiform is not a short bone, but bones of the carpus are mainly short bones. Yes, apart from that, we're also going to have what we call flat bones. Yes, flat, as the name suggests, they are flat morphologically. Yes, so we can see in our picture, in a slide, we can see that of the sternum. So the sternum is the breastbone, being a flat bone. Yes, apart from the sternum, the ribs, yes, the ribs, the costal bones are also flat bones. Yes, apart from that, we're also going to have the scapula, the shoulder blade, being a flat bone. Then mainly we are going to look at bones that form cranium of the skull. They are also going to be flat bones. So that is mainly, one thing that we are going to find. Now, one thing that you have to generally know is that long bones will generally undergo what we call endochondral ossification. Endochondral ossification. Now, what do we mean by endochondral ossification? We'll explain it when we get there, but we're going to use what we call, Hyaline cartilage model, to build on our new bone. But for flat bones will undergo what we call intramembranous ossification. Intramembranous ossification. So forming bone from scratch from connective tissue mesenchyme, from the mesenchymal cells, giving us that kind of bone. Then we also have what we call the irregular bones. For irregular bones, yeah, they don't have particular shape, they are irregular, so to speak. Yes, an example that we find over here is what we call the bones of the vertebrae. So bones of the backbone are irregular bones. Apart from that, yes, some of the facial bones, yes, mainly are going to be, irregular bones. Apart from that, yes, bones of the tarsus, talking about calcaneus, talking about talus, yes, these are actually going to be, what we call, irregular bones. Yes, apart from that, bones of the pelvis that you can see in your picture, yes, they are also going to be what we call irregular bones. Now, there is this bone which I've already hinted on it, that's the sesamoid bone, which are found within, they're actually irregular bones anyway, but they are found within what we call tendons. They are found within tendons, and that is which we call them sesamoid bones. So the commonest sesamoid bone that we have in your picture is the patella, that's the kneecap, is a sesamoid bone. Apart from that, of course, the pisiform, and of course, in the toes, bones of the toes, the phalanges of the toes, they are also going to be, some, sesamoid bones also being there. So as we said, yes, long bones are going to have two ends, two bulging ends, as you can see in the slide. Yes, we are going to have what we call two epiphyses. So a proximal epiphysis and of course a distal epiphysis. Then connecting them, yes, by way of the shafts, the longer portion being what we call the diaphysis, Now remember that, yes, within what we call the epiphysis, there will be what we call epiphyseal plate. Now epiphyseal plate, which I'm going to show you, is made of hyaline cartilage, and it's going to be very important by way of helping in what you call interstitial growth of the bone. Now interstitial growth of the bone is going to help in bone elongation, so that the bone can actually increase in its length. So that what will happen is that when you were young, your height was shorter relatively compared to your present circumstance. So right now you are taller than you used to be some perhaps 5 or 10 years ago, and it's because of what we call interstitial bone growth, and it's happening within the epiphyseal plate. Now this epiphyseal plate that you can see in the slide will be transformed to become epiphyseal line. Now the fusion of the epiphyseal plate to form the epiphyseal line marks the end of interstitial bone growth, so that you can actually increase the length of these long bones again. Now for females, we expect that their epiphyseal plates get fused to form a epiphyseal line about 2 to 3 years earlier compared to that of males. So that generally we expect, barring genetics and any other factor, then we expect that males should generally be taller than that of females. Now again, as you can see in the slide, you can see some connective tissue around the diaphysis of the bone, which you can see known as periosteum, a double layered connective tissue that we find over there, known as periosteum. Now this periosteum, yes, is actually connective tissue which is going to have what we call periosteal vessels actually entering it to supply it. But this periosteum, yes, because it's rich in blood vessels, it's also going to have give it some kind of supply to the bone cells. It's going to nourish the bone cells. Now this periosteum is connected or is attached to the bone, the underlying bone, by way of what we call some fibers. We call them Sharp's fibers. So the Sharp's fibers are going to connect these this periosteum to the underlying bone. So that's one thing that we are going to find. Now again, having talked about periosteum, then the inner portion, if you enter the bone, then we are going to have what we call the medullary cavity. So the central portion, the central cavity of the bone, is known as medullary cavity. Now within the medullary cavity, we'll have what we call bone marrow. So as I indicated, that bone marrow, yes, we're going to have the red bone marrow, and red bone marrow mainly is for hematopoiesis, production of blood cells. And then we also have yellow bone marrow for erythropoiesis band. But if you can see the diaphysis, the shaft, what happens is that in the shaft we have a lot of the yellow bone marrow. So mainly the shaft, you have a lot of fat stored there. But in the ends, in the epiphysis, you can see some spongy like areas, and that's what we call spongy bone, because over there you have a lot of red bone marrow for production of blood cells. So that's one thing we are going to find. Now, lying in the cavity of the medullary cavity, we will have what we call endosteum. Endosteum is also connective tissue over there. Now, within the endosteum, yes, you have what we call some osteoblasts as well over there. Now, within the periosteum, we also have some osteoblasts being there. Now, remember that you have some cells which you call them osteoblasts, which are going to form, which we are going to see. Then we also have what you call osteoclasts. Now, we expect that there's a balance between these ones. So while yes, in the periosteum, now I've already explained something we call interstitial growth. That's increase in length and so happening at the epiphyseal plate. Now there is another bone growth which we call it appositional growth. So apposition, adding onto the bone so that you increase the girth or the thickness of the bone, the width of the bone, so to speak, so that the bone can become broad. That's one thing that is going to happen. Now, usually we will add it from outside, so it's going to take place in the periosteum. Now, within the endosteum, we have some cells too over there known as osteoclasts. Now, osteoclasts are going to resorb. So as bone formation is taking place, or bone addition is taking place from the periosteum. Bone resorption takes place from the endosteum in the opposite manner. So that's one thing that we're going to find. Now, one other thing too that we have to know is the articular cartilages. Now, bones will form articulations like this. Is a long bone, so that you can see that at the ends of the bones they will be lined by what we call hyaline cartilage, forming what we call the articular or joint cartilage. So in your slide, as I was saying, yes, we are going to find what we call the epiphyseal plate. Yes, this in children. So it means that once you can see epiphyseal plate, then of course still there's potential for interstitial growth. And then of course you can see that, yes, you can see those hollow areas, they represent the spongy bone area. Yes, that's the articular cartilage that you find over there. And then of course there will also be what we call epiphyseal vessels too as well, over there. And of course metaphyseal vessels. Now I told you that from the diaphysis to the epiphysis we will meet what we call metaphysis. So here what I'm interested in showing you is that, yes, if we look at long bones, we will have what we call nutrient foramina. So in the nutrient foramina we will have what we call nutrient vessels. So we have nutrient artery, and of course nutrient artery supplying the bone with oxygenated blood, and a nutrient vein draining it. So that's one thing that we're going to find. Yes, of course I've already explained that of the periosteal vessels being there. Apart from periosteal vessels, we also have periosteal nerve, so that this periosteum is sensitive to pain. Of course I've mentioned metaphyseal vessels also being there, and of course epiphyseal vessels as well. So that is one thing that we are going to find actually. Now this is the morphology of the flat bone. Now if you take the flat bone, what we find is that I've taken this section from the bone of the cranium of the skull. Now you see that over there we have about 3 layers that you can see on the bone that we have shown, we have actually enlarged. So you find that we have the outer portion being the outer compact bone, then we have the inner compact bone, then in between them we have a layer of spongy tissue. Now this layer of spongy tissue is known as diploe. So diploe, in between the two compact bones we have an outer compact bone, a layer of outer compact bone, a layer of inner compact bone, sandwiching what we call the diploe or the spongy bone. Remember that spongy bone is also known as cancellous bone. So now this compact bone can also be referred to what we call cortical bone. So over here, if you hear cortical bone, then we're talking about the compact bone which sandwich, the spongy, bone. Now remember that yes, over there too, what we see is that you see that in the spongy bone is like spongy like, and it forms what you call trabeculae, which was actually formed from confluence of what you call spicules. So that is one thing that we are going to find. So at this point, we want to actually do a self-assessment, quick one, so that you can actually help us follow what we are doing. So quickly, yes, by classify the following into based on shape of bones. Yes, we look at vertebrae, sphenoid and ethmoid. Yes, of course, I'm sure you're going to answer that. Yes, it's going to be what you call irregular bones. Now the bones of each of your fingers, that the fingers and toes, which you call them phalanges, together with humerus. Yes, what type of bone? So of course that is long bone. But of course, remember that if you talk about that of the fingers and of course the toes, the phalanges, they are actually miniature long bones. Now if you look at ribs, scapula, yes, most bones of the skull, the cranium, and of course the sternum, yes, they are actually going to be flat bones. Then of course if you talk about the kneecap, that's the patella, and of course the pisiform, yes, they are going to be what you call sesamoid bones because they are found within tendons. Yes, if you take the calcaneus, that's the heel bone, it is actually an irregular bone. Yes, bone found within tendons, of course, it's going to be sesamoid bones. And then this one, yes, actually, yes, tiny irregular shaped bones that appear within sutures of the skull. This one is not actually explained, but it's not usually general shape, but they are actually known as sutural bones or Wemian, bones. Now, if we look at this, now we're actually going to look at cells of the bone proper. Now, there are 4 cell types of the bone, 4 cell type of the bone tissue, and the stem cell is known as osteogenic cell. Now this osteogenic cell, yes, can actually be referred to also as what you call osteoprogenitor cell. Now this osteoprogenitor cell, yes, will have high mitotic activities, or actually derived from what you call cells of the connective tissue mesenchyme. So they are derived from mesenchymal cells, serving as actually stem cell of what we call the bone, so that yes, it will undergo mitosis to give rise to what we call the osteoblast. Now they are usually found in the inner aspects of what we call the periosteum as well as the endosteum. So that's where you are going to actually find them. So that is the osteoprogenitor cells. So from your left, okay, osteoprogenitor cells. Now osteoprogenitor cells will give rise to what we call osteoblasts. Now anytime you hear the word blast, then they forming cells, osteoblasts. So cells that are going to form the matrix or especially the matrix of the bone. So that's the osteoblast. Now for osteoblasts lack mitotic activity. They lack mitotic activity, so that they are osteogenic cells. Yes, they are serving as stem cells which will undergo mitosis to give rise to osteoblasts which lack mitotic activities. But what happens is that they are going to help secrete what we call the extracellular matrix, mainly by secreting what we call collagen. So that's one thing that we are going to find. Now again, if there is high osteoblast activity, then alkaline phosphatase levels also increase. So that's one key thing that you have to actually know. So they are going to form it. Now after forming it, they will become entrapped within their own matrix. Now the matrix that they form what we call lacunae. And this lacunae, yes, will get trap the osteoblast which has formed the newly formed matrix. Now remember that the newly formed matrix, which is not calcified, is known as osteoid. So it will entrap, it will get entrapped within its own matrix, and then it will form what you call osteocyte. Now look at the osteoblast. Now the osteoblast is having a lot of protein synthesis machinery. So within the cytoplasm, as you can see, have rough endoplasm, numerous of them. You have Golgi apparatus, of course, free ribosomes are also there. So we're telling you that it has high protein synthesis machinery. Collagen is a protein. So now it will differentiate, or so to speak, it will actually get entrapped within its own matrix to become osteocyte. Now if you look at the cytoplasm of the osteocyte, it is lacking these protein synthesis organelles. But what happens is that it's also going to, every time you hear the word site, then it maintains. So it's also going to help in some kind of repair. If there is a need to make some extracellular matrix, then it can also do that, but not to that extent that osteoblasts will do. Again, you can see a lot of cytoplasmic extensions coming from what we call the osteocyte. A lot of cytoplasmic extensions, and these extensions, or processes, will lie in some spaces, tiny channels within the bone known as canaliculi, so that adjacent osteocytes can communicate. But again, these osteocytes will also be relevant in what we call exchange of nutrients, as well as waste between the blood, so that the waste which has been made by the bone will be taken into the blood by way of diffusion. Then of course, nutrients and oxygen can diffuse into the bone tissue, by way of diffusion into the bone tissue. So these things are also regulated by the osteocyte. Now I told you that there are 4 cell types in the bone tissue. We've seen 3 of them. Yes, osteoprogenitor cells, osteoblasts, to osteocyte. But there is a 4th one. Now the 4th one doesn't come from osteocyte, but it comes from a different cell line altogether, and that is what we call osteoclast. Now this cell line, yes, is coming from actually the myeloid lineage, coming from what we call monocyte. So as you can see from left, you can see about 5 monocytes fusing to form a single osteoclast. Therefore, osteoclasts are multinucleated cells, and therefore you can call them syncytium. So they are mainly going to be relevant for bone resorption. And by way of bone resorption, they are actually endowed with a ruffled border. They have a ruffled border. So as you can see, those finger-like projections coming from the cytoplasm, that forms the ruffled border, and then that increases the surface area for actual bone resorption. Again, within the cytoplasm, you can see a lot of lysosomes, and lysosomes will contain enzymes actually, which are going to help in bone resorption. So that is one thing that you have to actually understand regarding these ones. Now for the fusion of monocytes, now this one you can see 5, but actually it can range from 3 up to 50 monocytes doing that kind of bone resorption or bone repair. So that is one thing that we have to know. Now just a quick assessment for us to actually understand this. But remember that generally what will happen is that from the age from prepubertal period all the way to about 20 years, then what will happen is that bone formation, so it means osteoblast activity, forming the matrix, will outwit that of osteoclast activity, bone resorption activity. So that at any point in time, osteoblast activity or bone formation is taking place, and then osteoclast activity, bone resorption or bone breakdown, is also taking place. So that between prepubertal age all the way to about age 20, then what happens is that bone formation outweighs bone resorption, and that's why generally as one grows, you tend to have increased bone mass. But around age 20 up to about age 30, what happens is that there's equilibrium between bone formation and bone resorption. So that there's equilibrium, so that you don't actually increase or reduce your bone mass. But beyond age 30, then what happens is that there's gradual increased bone resorption compared to that of bone formation. At the extreme, then it can lead to what we call osteoporosis, which we are going to look at. So these are how these ones happen, and that is why at old age people tend to have reduced bone mass compared to when they were young. So that's why. So let's do this quick assessment. Now, mature bone cells are known as osteocytes, and that is true. only osteoblasts form the bone matrix. This is not entirely true, yes, because by way of maintaining, the matrix, that's the osteocytes, yes, they are also going to help form the matrix as well. But mainly the job is done by osteoblasts. But it's not only the osteoblasts which will form the bone matrix. Now both osteoclasts and osteoblasts reside in Howship's lacunae. No. Now one thing is that, yes, I told you that the extracellular matrix which will be formed, yes, that area that the osteocyte will lie is known as lacunae. So that's where lacunae will generally lie. But osteoclasts, which are the resorbing, yes, bones, will lie in a special lacunae which we call them Howship's lacunae. So osteoblasts, yes, themselves, they won't lie in lacunae, because osteocytes are rather supposed to be lying in lacunae. And of course, osteocyte will lie in Howship's lacunae. It's only osteoclasts which will reside in Howship's lacunae. Now the next one is bone building cells are called osteoprogenitor cells. No, they represent the stem cells of the bone. Now the bone building cells are the osteoblasts. Osteoclasts arise from fusion of up to 50 monocytes. Okay, and they are what? Bone resorbing cells. Yes, that's very true. Yes, they actually arise to up to, from monocyte, up to 50 of them, and they are going to help resorb, they are bone resorbing, cells actually. Osteocytes, arise from, yes, osteoblasts, and then give rise to osteoclasts. Yes, it's true that osteocytes will emerge from osteoblasts, but they won't continue to give rise to osteoclasts. Osteoclasts will come from a different cell lineage altogether, from monocyte, fusion of monocyte. So therefore, we can say that osteoclasts are the bone macrophage. Now, osteocytes and osteoblasts have ruffled border. No, ruffled border is found in only osteoblasts to give it large surface area for bone resorption. And the last one, increased, yes, osteoblast activity is associated with high levels of alkaline phosphatase. That's a very true statement, which we've already, indicated that. So very important, yes, bone, just like any other connective tissue, will have cells, which we've looked at. Then it will also have what you call, extracellular matrix. Now for the extracellular matrix, we are going to divide it into two main groups. We have the inorganic component and the organic component. Now remember that the inorganic component, together with water, will contribute 75%, and then the organic component will contribute just 25%. Now if you talk about the inorganic component excluding water, then it will consist of 50% of the total volume of the bone tissue. And this inorganic component is going to be important by providing support to what we call the bone, because they are going to form what we call the mineral matrix of the bone. They are going to form the mineral matrix. So 85% of this inorganic component is made of what we call hydroxyapatite, where it's actually a compound formed from calcium, phosphate, and of course hydroxide groups. So that's hydroxyapatite. Then of course 10% will constitute what we call calcium carbonate. 10% of this inorganic component will be calcium carbonate, with just 5% being other minerals, mainly fluoride and of course phosphate. Now one important thing is that this one is going to confer strength to the bone, because that's the mineral component. So that if the mineral component is not there, then it leads to what we call osteomalacia. So if the mineral component, which is the inorganic component, if there's decreased levels of it, it leads to what we call osteomalacia. Malacia has to do with soft, making the bone actually becoming soft, because the mineral matrix, which is going to make the bone hard, is not there. And so M for matrix, osteomalacia, weakness of the bone because of lack of mineral component. Now that's in adults, but in children or in young people, we call it what you call rickets, and that's results in what we call bending, either lateral bending or forward bending of the bones. Now apart from that, an important component of the bone is water. Water will constitute 25% of the matrix of the bone. matrix of the bone. So that is with water. Then for the organic component is the protein component. And we talk about protein, that's the collagen, and it's going to be important in conferring resilience to the bone. So organic component, that's the collagen, mainly collagen type 1, will be important in conferring strength to the bone. Now this organic component, the newly formed organic component, that's the collagen, where it's formed, we call it osteoid. Now if the protein component is not there, yes, and for that matter bone formation is not taking place quite early, and there's increased bone resorption, then it leads to what we call osteoporosis. So P for protein, that's the protein component for collagen, and therefore P, osteoporosis, leading to that. Now remember that osteoporosis will mainly take place, especially when you look at post-menopausal, yes, females, because of course it's been known that estrogen plays an important role as far as bone formation is concerned. So post menopausal stage, then what will happen is that females tend to be susceptible to osteoporosis. Now an important aspect which we have to talk about regarding this organic component is what we call brittle bone disease. Now this brittle bone disease is very important. We also call it osteogenesis imperfecta, and this disorder is actually a genetic disorder. Yes, as a result of lack of collagen production, production of collagen, and results therefore in brittle bone. Now remember that you require the organic component so that you can put on your inorganic component, or the inorganic component is laid on the organic component, so that without the organic component, then you also don't have the place or the platform to lay the inorganic component. Then it means that of course then there will be brittleness of the bone, so the bone is going to be susceptible to what we call fractures. Now if we are not producing collagen, then it means that generally wherever we need collagen, you are not going to have it, like the tooth. So it means that such individuals is also present with what we call brittle tooth. Yes, apart from this, they present what we call triangular shaped face, also with broad forehead actually. Yes, they also present with what we call short, small body. Yes, of course, apart from this, they will also have what we call curved spine, presented as kyphosis. Then apart from this, they also have what we call bluish sclera, okay, or apart from that, it will be purplish or gray in nature. Then they also have what we call barrel shaped rib cage. So these are some disorders, because they will generally not be able to produce what you call collagen, presenting with these classical symptoms. So that is one thing that we have to actually understand regarding what we call the organic component. So regarding the inorganic component, that's the mineral matrix, disorder is osteomalacia. For the organic component, the protein component, osteoporosis. So now, having seen these ones, generally we have two kinds of bone depending on the structure, the hardness, how the bone is actually organized. And therefore we have what we call compact bone, and then we have what we call spongy bone, or the cancellous bone. Now for compact bone, what we find is that we are going to find that it's going to have a system which you call it Herbacean system. So the Herbacean system represents what you call the circumferentially arranged laminae, okay, like cylinders, packing cylinders, smaller cylinders, different sizes, and then having a central cavity which you call as Herbacean canal. So now this one is a cross section of the bone, compact bone, actually a long bone. Now what we find is that you can see that of the laminae, circumferentially arranged laminae, forming what we call the Herbacean system. Now another name for the Herbacean system is osteon. Now within these laminae, we are going to have what we call lacunae, and lacunae represent what we call the house where the osteocytes are going to dwell. So as you can see on the extreme right side of it, you can see an osteocyte lying in a lacunae, and having those processes. and those processes extend through what we call canaliculi, the spaces over there known as canaliculi, so that adjacent osteocytes can communicate. Okay, can communicate. Now remember that one osteon or one Haversian system will communicate with the other through what we call, perforating canal, through what we call perforating canal. So one Haversian system communicates with the other through what we call perforating canal or Volkmann's canal. Volkmann's canal. So that is one thing that we are going to see. Now remember that within what we call a Haversian system, that's the osteon, we have what we call the Haversian, blood vessels. You have the blood vessels, that's the artery. We're going to have what's called the vein. Then apart from that, there will also be what we call lymphatics as well being there. So that is one thing that we are going to find over there. Now, so the laminae, we have what we call the concentric laminae, which are actually going to form the osteon. Then of course, adjacent to what we call the osteon, we're also going to have what we call interstitial laminae. Interstitial laminae. Now, as you move away from the compact bone and you get where we have the medullary, cavity, then we have what we call the spongy bone, which of course that area will be endowed with what we call red bone marrow. So that is one thing that we are going to see regarding this slide that you find over there, and that is generally the architecture that you are going to find regarding this bone. But of course, again, this bone will also present with what we call cement lines. Cement lines will actually also be there. So mainly that is one thing that we're going to find. So with this slide, what I want you to know is that you have to know that we have Haversian systems. That's the concentrically arranged laminae, which is also known as osteon. And remember that within the osteon we have what we call a cavity over there known as the Haversian canal, and within the canal we have blood vessels and we have lymphatics as well in there. Now remember that within the concentric laminae we are going to have what we call lacunae, which will house osteocytes. Osteocytes will have cytoplasmic processes which will lie in canaliculi, little channels, so that adjacent osteocyte can communicate. Now connecting one Haversian canal to the other is known as the Volkmann's canal or the perforating canal. So that is one thing that we are going to find actually. Now compact bone, yes, is going to actually confer strength to the bone generally. Now this is the spongy bone. Now as you can see, it has spongy appearance with a lot of cavities in there, and therefore we can see those kind of trabeculae which are actually formed from what we call spicules. So that's the trabeculae over there, and within the spaces which are enclosed by the trabeculae are what we call the spaces for the bone marrow. Red bone marrow actually will be there. So as I said, it's going to have spongy-like appearance, but these ones are not organized into osteons or Haversian systems. They have those irregular areas which called the trabeculae, which will be filled with what we call the bone marrow. Now remember that yes, osteocytes get their nutrient directly from circulating blood. This time around, osteocytes won't get their blood through any other means, but they will get it through directly from circulating blood, which will flow through the bone marrow actually. Now this type of bone will be important in conference strength with lifting weight. Now because there are a lot of air-filled spaces within there by way of trabeculae spaces in there, then it means that it's not going to carry a lot of weight, but it's also it's very important in actually helping providing strength to the bone generally. Now mainly, unlike compact bone where mostly we find them in long bones, now these ones you are going to find them in flat bones, yes, irregular bones, as well as short bones mainly. But remember that they will be covered by a layer of compact bone, but within it majority will be this spongy bone actually. So just a quick assessment regarding this. Let's see what we have now. A two-layered tissue that covers a bone is known as periosteum. Yes, that's very true. So periosteum is double layered. It's going to actually, yes, do that. Now, a dense part of a bone is the compact bone. Yes, dense part of the bone, yes, is the compact bone. But for the less dense one is, of course, the spongy bone. Hydroxyapatite is the inorganic component of bone that confers strength. Yes, that's very true. Hydroxyapatite is contributing about 85% of the inorganic component. Then, of course, diaphyses of long bones are endowed with spongy bone tissue. So, yes, there will be some spongy bone tissue, but they are not well endowed. It's actually the epiphysis which will be well endowed with, spongy bone tissue. Now, in adults, if there is high demand of red blood cells, yellow bone marrow can be converted to red bone marrow for effective, erythropoiesis. This is not the case. Yes, this is not the case. Once yellow bone marrow has formed, it is irreversible. Unless, of course, if the disorder is persistent, then there has to be what we call extramedullary erythropoiesis, which may happen in the liver, the spleen, and some other organs, but not converting the yellow bone marrow to red bone marrow. Now, unlike ligaments which connect bone to muscle, tendons connect bone to bone. No, yes, ligaments are actually going to connect bone to bone, but tendons will connect, yes, bone to muscle. So that's not true. Then, of course, areas in adults where red bone marrow could be assessed for various myelodysplastic studies include the Steinman and iliac crest. Yes, of course, these are the main commonest areas where in the adults we can access red bone marrow for various myelodysplastic. Now, the word myelo has to do with the bone marrow, and dysplastic, irregular. Myelo can also be could also be related to what we call the spinal cord, but of course in this case we are looking at the bone marrow. So myelodysplastic, any irregularities that happen with the bone marrow, yes, we can study it by taking bone marrow from the sternum or the breastbone, and of course the iliac crest, because of course in the fetal life and of course youthful stage, or let me say early childhood, then what will happen is that most areas of the bone will have a lot of red bone marrow, but as you age, then what will happen is that these areas, most of them will get converted to yellow bone marrow. All right, now we want to actually look at these ones. Now remember that we said that with bone development or bone formation, there's actually around the 6th week of intrauterine life, but of course, depending on the type of bone, the time may change. But generally from 6th week of intrauterine life, there are two kinds of bone formation. We have what we call intramembranous bone formation or endochondral ossification, and then also have what we call intramembranous bone formation or intramembranous ossification, and of course endochondral ossification. Now, for intramembranous ossification, yes, it's formed from what we call, scratch from connective tissue mesenchyme, Then for endochondral ossification, it's going to be formed from what we call, cartilage model. That's hyaline cartilage, model. So actually, ossification has to do with the bone development which is going to take place. Now, if you look at the intramembranous ossification, what will happen is that the mesenchymal cells, which you can see on your extreme left side. Now for the one, now what happens is that mesenchymal cells, will get differentiated to become what we call osteoblasts. Of course, they will become osteogenic cells and then eventually to osteoblasts. Now when they become osteoblasts, then what will happen is that they form what we call the primary ossification center. Now this one is going to take place in the thickened regions of the connective tissue mesenchyme. Now, once this primary ossification center has formed, and we have osteoblasts being there, then the osteoblasts begin to secrete the organic component of the bone. That's the osteoid. So they secrete the osteoid, into the area. Now remember that that's the organic, the neuriform matrix, which is uncalcified, is the osteoid. Now immediately this osteoid is secreted, then what will happen is that this osteoid will actually be, they will be entrapped. Why? Because what will happen is that there will be calcium deposition or mineral deposition into the matrix. So this deposition which will take place will calcify the matrix, and therefore what will happen is that these osteoblasts will actually be entrapped to become what we call osteocytes. Just a few days, after mineralization, they will form what we call osteocytes. Now, what will happen is that after this osteocyte has been formed, then what will happen is that we form what we call woven bone, or the spongy bone will actually form. Okay, so spongy bone or the woven bone will form. Okay, over there, as you can see at the number 3 on your left hand side. So spongy bone will actually form, and or the woven bone will form, and it will be surrounded by what we call periosteum. So once the spongy bone forms, it will be surrounded by what we call periosteum. Then later, yes, you can see that blood vessels are invading it, so it will be vascularized. So there will be new angiogenesis. That's new blood vessels will actually form over there, and then eventually we form what we call bone collar. So compact bone will actually cover where we have what we call the woven bone or the spongy bone. It will cover it, and that is what we call bone collar. And of course, once bone collar forms, there will be appearance of bone marrow within it. So as you can see, there will be bone marrow within it. So as it covers it, then within it we have bone marrow within it, covering what we have, being around where we have the spongy bone. So that is what we call intramembranous ossification. So remember that in intramembranous ossification, we are going to have connective tissue mesenchymal cells, which will be transformed to be what we call osteogenic cells, and then from osteogenic cells they become osteoblasts, and they will form the primary ossification center, which of course will begin secreting the newly formed organic matrix. That's the osteoid, and this osteoid, yes, will be mineralized, will be calcified, and then of course they will be trapped to form what we call osteocytes. So once osteoblast, the matrix has been formed, then we call it osteocyte. Then of course, apart from osteocyte form, then what will happen is that they will begin to make the woven bone. Okay, and it will be covered by what we call the periosteum. New blood vessels will also begin to form, new angiogenesis will take place, and then what will happen is that, yes, bone collar will form. Now remember that in the formation of the woven bone, what will happen is that, yes, there will be confluence of what we call spicules, which will form what we call trabeculae. That's the woven bone that we are going to form, and of course there will be a layer of compact bone covering it. And so that is what we mean by intramembranous ossification. Now for intramembranous ossification, it's going to take place mainly, yes, in flat bones. As we said, flat bones are going to go through intramembranous ossification. Now on the extreme right hand side, we are going to find what we call endochondral ossification. Now for endochondral ossification, it's going to start from what we call a cartilage model. And what type of cartilage? Hyaline cartilage model. So the fetal hyaline, yes, will therefore serve as model for this kind of bone formation. So what we are going to find is that chondrocyte will go through what we call hypertrophy, and then the matrix will calcify, actually. So chondrocytes will go through hypertrophy, and then matrix will calcify mainly. That is what is going to happen. And then when that happens, now you will see that there will be what bone collar will form, at the diaphysis. Bone collar will form at the diaphysis. Now over there is when we have what we call the primary ossification center forming. Primary ossification. Now remember that primary ossification center will always happen in the shaft, in the diaphysis. Secondary ossification centers will happen in the epiphysis, So what will happen is that, yes, after the chondrocytes have undergone hypertrophy and the matrix calcifies, if it calcifies, then it means there will be the diffusion of nutrients into the matrix. Therefore the chondrocytes will begin to die. They'll begin to die. Now once they die, then they will be invaded by what we call the they will be invaded by what we call the osteoblasts. And these osteoblasts will actually come from what we call the perichondrium, actually. So as I said, yes, chondrocytes will undergo hypertrophy and the matrix will calcify. When it calcifies, the bone cell, so the cartilage cells are not getting nourishment, therefore they begin to die. And that is when we say that periosteal bone quala, yes, will form around the periosteum, and this will create some kind of a shell, yes, of bone around the diaphysis. Now I said that there will be invasion of what we call osteogenic cells by way of osteoblasts will invade there, forming what we call the primary ossification center in the diaphysis. So that is one thing, we will invade it over there. Now anytime the osteoblasts, so once the osteoblasts come in there, then there will be new angiogenesis, new blood vessels will begin to form. And what will happen is that secondary ossification center, yes, will form in the epiphysis. In the epiphysis, secondary ossification center will form there. Now bone will therefore eventually replace all the cartilage cells in there, because what will happen is that the osteoblasts will continuously secrete what we call the unmineralized matrix, which will later be calcified, but this whole process will actually take place in the entire long bone, with the exception of what we call the articular cartilage as well as the epiphyseal plate. Then later, of course, the epiphyseal plate will ossify in later life and then form what we call epiphyseal line. And then of course for the articular cartilage, they will remain calcified. So that is one thing that you are going to find with endochondral ossification. So for endochondral ossification, yes, the cartilage, yes, will become will die because of lack of blood vessel, because the mineral the matrix will be calcified. Then bone quala will form around the periosteal area, bone quala will form, and then of course primary ossification center will form in the diaphysis through invasion of the osteoblasts in there. Then of course secondary ossification center will happen in the epiphysis. Then there will be new angiogenesis. There will continuously be formation of new matrix, osteoid will form, which will get calcified. And then of course eventually we will actually go through ossification for almost all the areas except what we call the articular cartilage as well as the epiphyseal plate, which of course the epiphyseal plate later will be converted to epiphyseal line when it gets fused. So that is what we call endochondral ossification. Now endochondral ossification will mainly happen in long bones using cartilage model, Harlan cartilage model. So this is what we actually explain, and this this is it. Now we have so the topmost one is the quiescent zone, and that is the zone of resting zone actually. So that's the resting zone. Now apart from the resting zone, yes, we also have what we call the growth or proliferating zone. Then we also have what we call the hypertrophic zone, or the zone of hypertrophy. Then the zone of calcification, of course, the osteogenic zone where new bone is formed. This is endochondral ossification. Now let's go through quickly. So there will be the resting zone. Now this quiescent zone or the resting zone, there's no bone cell over there, and it's quite near the epiphyseal plate. Now over there we have actually scattered chondrocytes being there, and they will actually be anchor what we call the epiphyseal plate to the bone. Okay, so that is the most superficial one, or the superficial most zone. Now the zone of proliferation, that's where the cartilage cells will begin to proliferate and get stacked onto one another like coins. So as you can see, okay, that's the zone of proliferation. They're undergoing high, they are highly mitotic, and therefore they will divide. Now anything that you have high mitosis happening in there, then you can also find mitotic figures also being there. Then we also have the zone of hypertrophy, where the cartilage cells will begin to enlarge. As we've said, they begin to enlarge and they will arrange in columns, and what will happen is that yes, it's going to actually increase in lengthwise expansion of the epiphyseal plate. Now for the zone of calcified cartilage, or the calcification zone, yes, few cells thick. Actually, as you can see, just a few cells thick. That's why the thickness is short. Then it's occupied mainly by osteoblasts, yes, of course, as well as osteoclasts will also be there. And of course, to be invaded by capillaries from what you call the diaphysis, yes. And of course, they will help to lay down, yes, the bone cells. Now, dead chondrocytes will be surrounded by what you call calcified matrix. So that's what I said, that because of the calcification, no blood vessels are coming. Therefore, the cartilage cells will begin to die. Then eventually, what we are going to see is that the matrix, or the area of osteogenic area or ossification area, yes, we are going to see that the matrix will actually resemble what we call long spicules, okay, of calcified matrix. Yes, actually, that's what we are going to find. And what we call the spicules will actually partially, yes, will get eroded by what we call osteoclasts, and then covered, in bone matrix, actually from what we call osteoblasts. So that's where we are going to find the spongy, yes, bone tissue also being there. So mainly this is what is going to happen. That is what we call the endochondral ossification. So you have to know the layers. The quiescent area, there is resting zone. We are going to have the proliferating zone, the hypertrophic zone, of course calcification zone, and of course the osteogenic zone. So this is actually showing, yes, the histology of intramembranous ossification, where we're talking about the spicules eventually forming what we call this trabecular network, leaving those kind of spongy like areas. Okay, so that is one thing. Mainly this is for intramembranous ossification. So just a quick self-assessment. Yes, most of the shaft of the clavicle goes through endochondral ossification. So for the clavicle, yes, the clavicle is a long bone, but most of its shaft will go through intramembranous ossification. Just a small portion of this medial end, or the sternal end, will go through endochondral ossification. So that's wrong. Unlike endochondral ossification, where it requires a hyaline cartilage model, in intramembranous ossification, bone is formed directly from connective tissue mesenchyme. That's very true. Intramembranous ossification is seen predominantly in flat bones. That's very true. Unlike interstitial and apophyseal growth, which are constant remodeling and bone creation, intramembranous and endochondral ossification involve the steps in creating new bone. That's actually true. And of course, primary centers of ossification are always within the epiphysis of long bones. No, primary centers will be in the diaphysis within the shafts, and then for secondary central ossification, they will be in the epiphysis. Now, by way of regulating, actually, yes, calcium mineralization of the bone, now 3 important hormones are very important. And these 3 hormones are known as calcitriol, or 1,25-dihydroxycholecalciferol. Yes, apart from that, we also have what we call calcitonin, and then of course parathyroid hormone. So we just actually want to go through these ones quickly. Now, for calcitriol, yes, it's actually made in the keratinocytes of the skin, okay, from actually cholesterol, actually 7-dehydroxy cholesterol. From cholesterol we are going to make what we call we're actually going to make cholecalciferol. Now this cholecalciferol, that's vitamin D, is actually inactive. Now it requires UV light from the sun to make it. Now you are not going to get it from the sun by merely standing in the sun. It's going to be made from cholesterol in your skin, okay, under your skin by the keratinocytes. Now this one is actually inactive, therefore will have to be activated. Now its activation is based on hydroxylation. Now it will go through 2 hydroxylations, one in the liver and one in the kidney. So in the hepatocytes of the liver, this cholecalciferol, the inactive form of vitamin D, will be converted to calcidiol. Now this calcidiol is 25-hydroxycholecalciferol, or 25 hydroxy vitamin D. Now this one, there will be another hydroxylation which will take place in the kidney by converting this calcidiol, or 25 hydroxycholecalciferol, into what we call calcitriol, which is the active form of the vitamin D, or 125 dihydroxycholecalciferol, which we've seen. Now this one, what it's going to do is that it's going to help increase what we call blood, calcium level. And how is it going to do that? By actually increasing bone resorption, bone breakdown, so that more calcium will relieve the bone into the blood. And apart from that, it's also going to increase what we call calcium reabsorption by the nephrons of the kidney. Kidney tubules are going to actually help in calcium absorption, as well as, of course, helping in calcium absorption in food. So that's by the kind courtesy of calcitriol. That's vitamin D. Very important active form of vitamin D. Apart from that, calcitonin, which is produced by the parafollicular cells, which actually come from the ultimobranchial bodies, also we can also call the the parafollicular cell the C cells or the clear cells. They are going to be produced. They are actually coming from the thyroid gland, and they will be important in actually reducing. This time around, they are going to tone down the blood calcium level. Now, how are they going to do that? Yes, they are going to actually reduce osteoclast activity, but rather stimulate osteoblast activity so that they form more bone, more matrix. And it will actually be important in correcting what you call hypercalcemia. So if there's too much too much calcium in the blood, then calcitonin will be released into the blood as hormone, and it is going to help reduce blood calcium levels through what we've discussed actually. Now, at the posterior aspect of the thyroid gland, we have what you call parathyroid glands. Actually, you have about 4 of them. Now, these ones are actually going to produce what we call parathyroid hormone, which we've seen over here. Now, this parathyroid hormone will actually increase, so it's antagonistic to that of calcitonin, will actually increase what we call blood calcium levels by actually stimulating what we call calcium reabsorption by the nephron of the kidney tubules. Actually, they also be important in actually promoting calcitriol biosynthesis in the kidney, so that we actually activate the vitamin D in the kidney to actually absorb more calcium, in the kidney, reabsorb more calcium, as well as, of course, in diet. Then also they will also be important. Now, this parathyroid hormone will be important in actually correcting what we call hypocalcemia, reduced blood calcium levels, so that we bring blood calcium level back to normalcy. Now, one thing that you have to know is that calcium is very important. Yes, we've been talking about calcium. It's very important in actually helping what we call acting potential of neurons, in muscle contraction, mainly the heart. Yes, it's going to dwell on it. Blood clotting is going to also depend on this, among other things which are going to happen in the body. So that's why calcium regulation or metabolism is very important. Now, so we've actually explained what we call osteoporosis being an important bit. So if these hormones are not well regulated, osteoporosis can actually set in, where we have more bone resorption but than bone formation. Actually, osteoporosis will be diagnosed on X-ray, where you have a lot of spongy areas, which I'll show you in as we move on. So as I said, just by way of regulating blood calcium level, if there's too much calcium in the blood, then what will happen is that calcitonin will be secreted into the blood, and when calcitonin is secreted, it reduces osteoclast activity or bone resorption activity, and it also actually promotes what you call osteoclast activity or bone formation activity. And so that is one thing that we are able to help correct, increase blood calcium, and that's hypercalcemia. Then, of course, for hypocalcemia, then low blood calcium level, then what will happen is that the parathyroid hormone will be stimulated. Parathyroid gland will be stimulated to secrete what we call parathyroid hormone, and this parathyroid hormone will increase osteoclast activity, leading to increased bone resorption, so that more calcium could be released into the blood. And of course, it will actually reduce what you call bone formation by way of reducing osteoblast activity. It will also actually help in actually unite a lot of phosphate, so that you don't combine with calcium to form hydroxyapatite, so that calcium will be actually reabsorbed in the urine, from the destined urine, so that it can be taken into the bloodstream, raising what we call blood calcium level. So that's what I actually want to show you. So on my left, you can see the normal bone, and on my right, you can see the osteoporotic bone. osteoporotic with a lot of holes in there. And this is actually what I have for you for today. So we will actually look at other aspects regarding our future discussions. Thank you very much for your audience.